Hello all. Today we'll be talking about a popliteal fossa, which is a very important topic in lower limb, and it is important in according to exam point of view. Popliteal fossa is a diamond-shaped depression posterior to the knee joint. You can see this diamond-shaped depression, and it is approximately 2.5 centimeters wide, and it is the most fat-filled compartment of the lower limb. And if we talk about the boundaries, what are the boundaries that form the popliteal fossa? So superficially, the popliteal fossa is bounded by the biceps femoris. You can see this is biceps femoris. Superomedially, there are two muscles, the semi-membranosis and lateral to which is the semitendinosus and the superomedial border of the semitendinosus. Now the inferior boundaries, inferior-laterally and inferior-medially, it is formed by the lateral and the medial heads of the gastrocnemius respectively, forming the inferior-lateral borders and the inferomedial borders. Now posteriorly, it is formed by the skin and the popliteal fascia, which forms the roof. The anterior wall or the floor of the fossa is formed by the popliteal surface of the femur, the posterior ligament of knee joint and the popliteus muscle. The roof is formed by the skin, superficial fascia and the deep fascia of thigh. Now whenever we talk about a fossa, we should know about the contents. What are the contents of that fossa? Now the contents of the popliteal fossa can be explained by this schematic diagram which shows the contents. And these are the small saphenous vein terminates here, the popliteal arteries and veins with their branches and tributaries, the tibial and the common fibular nerves, posterior cutaneous nerve of thigh, articular branch of obturator nerve, and some popliteal lymph nodes and lymphatic vessels. So there is another diagram showing you the same. You can see the popliteal fossa, and here is popliteal artery, which is well visualized in this diagram. Now the fascia of the popliteal fossa. Some important features of the popliteal fossa's fascia is that it is the subcutaneous tissue or the superficial fascia. It contains the small saphenous vein. Unless it has penetrated the deep fascia of the leg at the more inferior level. The other contents of the fascia are the three cutaneous nerves, which are the terminal branches of posterior cutaneous nerve of thigh, medial and lateral sural cutaneous nerves. Now one thing important about the popliteal fascia is that it is a strong sheet of deep fascia and it is continuous superiorly with the fascia lata and inferiorly with the deep fascia of leg. Now we will take the contents one by one. So the first content is the popliteal artery, and this popliteal artery is deeply placed in the fossa and it enters the popliteal fossa through the opening in the adductor magnus. This is the adductor magnus which you can see, and the entry of this popliteal artery is very well visualized. It is a continuation of the femoral artery and it ends at the level of the lower border of the popliteus muscle. You can see here this is the popliteus muscle, the lower border of the popliteus muscle, by dividing it into anterior and the posterior tibial arteries. So this is a course of popliteal artery in the popliteal fossa. If we talk about the relations, anteriorly it is related to the popliteal surface of femur, knee joint and the popliteus muscle. Posteriorly, it is related with the popliteal vein, the tibial nerve, fascia and skin. And if we see about the branches of the popliteal artery in the popliteal fossa, it has muscular and the articular branches. Now, if you can see that the popliteal vein, it is usually superficial and adjacent to the artery, but in some cases it may run deep to the artery or be separated from it by a slip of muscle which can be derived from the medial head of the gastrocnemius. Now the arterial anastomosis around the knee joint, which is very important. Anastomosis anywhere in the body plays a very important role. Now 5 genicular branches of the popliteal artery supply the capsule and ligaments of the knee joint. So here is the diagram showing you the anastomosis around the knee joint. Now the genicular arteries are the superior lateral. So this is the superior lateral, superior medial. Then the next is the middle genicular. The other are the inferior lateral and the inferior medial genicular arteries. So these are the anastomosis. These are the arteries which form the anastomosis around the knee joint. Other contributors to this important genicular anastomosis are the descending genicular, which is a branch of femoral artery, descending branch of the lateral femoral circumflex artery, anterior tibial recurrent artery. So whenever if some branches are obstructed, the other branches they come into major role and the circulation around the knee joint is maintained, because there are a range of movements around the knee joint, so the arteries may be compressed. So this genicular anastomosis is very important. Now the muscular branches of popliteal artery, they supply the hamstring, gastrocnemius, soleus and the plantaris muscle of the lower limb. Now the neurovascular structures. So one thing which you have to keep in mind in the popliteal fossa is the orientation of the vascular structures in it, which is very frequently asked in the viva. So from superficial to deep, or you can say that from posterior to anterior within the fossa, as we see in dissection, the nerves are encountered first, then the veins and the arteries lie deepest. So this is the orientation which we have to keep in mind. The arteries lying deepest, they directly lie on the surface of the femur, the joint capsule and the investing fascia of the popliteus, forming the floor of the fossa. Now the nerves in the popliteal fossa, you can see here the sciatic nerve, which usually ends at the superior angle of the fossa by dividing it into tibial and the common fibular nerves. The tibial nerve is the medial largest terminal branch of the sciatic nerve. So this is the tibial nerve and this is the common peroneal nerve. Now the tibial nerve is the medial larger branch, is the most superficial of the three main central components of the popliteal fossa, that is the nerve, vein and artery. It bisects the fossa as it passes from its superior to the inferior angle. While in the fossa, the tibial nerve gives branches to the soleus, gastrocnemius, plantaris and popliteus muscle. The medial sural cutaneous nerve, which you can see here, is also derived from the tibial nerve in the popliteal fossa, and it is joined by the sural communicating branch of common fibular nerve at the higher level to form the sural nerve. So this is the sural nerve, which we'll see in another diagram, and this nerve supplies the lateral side of the leg and ankle. Now if we talk about the common fibular nerve, which is the lateral smaller terminal branch of the sciatic nerve, it begins at the superior angle of the popliteal fossa, which you can see very well, and it follows closely the medial border of the biceps femoris and its tendon along the superior lateral boundary of the popliteal fossa. So this is the common fibular nerve following closely the medial border of the biceps femoris, and it leaves the fossa by passing superficially to the lateral head of gastrocnemius and then passes over the posterior aspect of the head of the fibula. Now the common fibular nerve, it winds around the neck of fibula and divides it into terminal branches. So this is another picture showing you the course of the tibial nerve and the common peroneal nerve in the popliteal fossa. You can see the tibial nerve and the common fibular the sciatic nerve dissecting into two branches at the superior angle of the popliteal fossa. Now one branch coming from the the tibial nerve and the other branch is the sural communicating branch of the common peroneal. So these two, they join together and form the sural nerve. Other branches which you can see is the lateral cutaneous nerve of the calf and small branches going to the muscles. So this is a line diagram to show you separately, and for you it will be easier to remember the tibial nerve and the common peroneal nerve, how they are going into the lower limb, what are the muscles they are supplying in the different regions of the lower limb. So you can see the coming from the sciatic nerve, it's coming from the sacral plexus, L4, L5, S1, S2 and S3, and this sciatic nerve, then how it goes into the gluteal region, back of thigh, lower limb, and here the same gluteal region, back of thigh and lower leg. So you can see the tibial nerve and the common peroneal nerve. In this part of the diagram, you can see the tibial nerve giving one twig to the hip joint, in the back of the thigh supplying the semitendinosus, biceps femoris, and the semi-membranosus, adductor magnus, the hamstring part. When it goes into the lower limb, which will be dealt separately in the lecture, the muscles that are supplied by the tibial nerve are the gastrocnemius, soleus, plantaris, popliteus, and the other muscles of the lower leg. If we talk about the common peroneal nerve, in the gluteal region it has no branches. In the back of the thigh it supplies the biceps femoris, short head. Long head was supplied by the tibial nerve. Gives a twig to the knee joint, and another branch is the lateral cutaneous nerve of the calf. In the lower leg, it is giving the sural communicating branch, which forms with the tibial, a branch of the tibial nerve to form sural nerve, and the other branches are given to the lower leg muscles. Now, coming to the applied part of the tibial nerve injury. So if the tibial nerve gets injured, we have read that it leaves the popliteal fossa by passing deep to the gastrocnemius and the soleus muscles. And because of its deep and protected position, fortunately it is rarely injured. And if injured, if there is a complete division, it will result in the following clinical features. And if the motor component, all the muscles in the back of the leg and the sole of the foot will be paralyzed. So the opposing muscles will dorsiflex the foot at the ankle joint, and in this diagram you can very well appreciate it will evert the foot at the subtalar and the transverse talar joints, and this attitude of this deformity is known as calcaneo valgus. So this is a normal foot, and if there is tibial nerve injury, you can see the foot which will become like this, and this attitude is known as calcaneo valgus. And if sensory part is involved, the sensation is lost on the sole of the foot. And since there will be no sensation, the person will not be able to appreciate injuries, and eventually trophic ulcers will develop, which you can see in these diagrams. So coming to the common peroneal nerve injury, the common peroneal nerve is in exposed position as compared to the tibial nerve, as when it leaves the popliteal fossa and when it winds around the neck of the fibula to enter the peroneus longus, so it is in an exposed position. Where is it commonly injured? It is injured in the fractures of the neck of the fibula, and it can be injured by the pressure from the cast or the splints. Now if this the peroneal nerve is injured, what will be the clinical features? The hamstring muscles are paralyzed, but there will be weak flexion of the knee because of the action of sartorius and gracilis, which are supplied by the femoral nerve and obturator nerve respectively. Now all the muscles of the knee, below the knee, will be paralyzed, and the weight of the foot causes it to assume the plantar flex position, or known as foot drop. So foot drop can be asked as a short note also. So you can appreciate that it is a normal foot. When the common peroneal nerve is injured, the inability to lift the front part of the foot of the ground happens, and there is foot drop. Now sensation is also lost below the knee, except for a narrow area down the medial side of the lower part of the leg and along the medial border of the foot, as far as the ball of the big toe, which is supplied by the saphenous nerve. So that is spared. Now the other contents of the popliteal fossa, the popliteal vein and the lymph nodes. Now the popliteal vein is formed by the junction of venae comitans of the anterior and the posterior tibial arteries at the lower border of the popliteus muscle on the medial side of popliteal artery. As it ascends through the fossa, it crosses behind the popliteal artery so that it comes to lie on its lateral side. It passes through the opening in the adductor magnus to become the femoral vein. Now, popliteal lymph nodes, about approximately 6 lymph nodes are embedded in the fatty connective tissue of the popliteal fossa. They receive superficial lymph vessels from the lateral side of foot and leg. These accompany the small saphenous vein into the popliteal fossa. They also receive lymph from the knee joint and from the deep lymph vessels accompanying the anterior and posterior tibial arteries. Now, one word about the popliteus muscle, which is an important muscle. It plays a key role in the movements of the knee joint. Now, if we talk about the muscle, we will talk about the origin, insertion, nerve supply, and action. So, if we look through this diagram, the origin is from the lateral surface of the lateral condyle of the femur by the rounded tendon and by few fibers from the lateral semilunar cartilage. So you can see the origin of the popliteus, and the fibers, they pass downwards and medially and are attached on the posterior surface of the tibia above the soleal line. Now, nerve supply is by the tibial nerve, as we have seen in the earlier slides. And the action of this popliteal muscle is that the medial rotation of the tibia on the femur, or if the foot is on the ground, lateral rotation of the femur on the tibia. Now this latter action occurs at the commencement of flexion of the extended knee, and its rotatory action slackens the ligaments of knee joint. So this action is sometimes referred to as unlocking of the knee joint. Now the applied aspect of the popliteal fossa, one is the popliteal aneurysm, which you can very well visualize here. The pulsations of the wall of the femoral artery against the tendon of adductor magnus at the opening of adductor magnus is thought to contribute the cause of aneurysm. Now, aneurysm is an abnormal dilatation of all or a part of the artery, and a popliteal aneurysm will be abnormal dilatation of all or a part of popliteal artery. Why we are concerned? Because it usually causes edema and pain in the popliteal fossa. And since the other causes should be distinguished, there should be a differential diagnosis by the other masses which can be formed by the palpable pulsations, which are known as thrills, and an abnormal arterial sound which is known as bruit, which is detectable with a stethoscope. Because the artery lies deep to the tibial nerve, an aneurysm may stretch the nerve or compress its blood supply, and pain from such nerve compression is usually referred into the area supplied by the by the nerve, from, as in this case, the skin overlying the medial aspect of calf, ankle, or the foot. Another important part is that if the femoral nerve artery must be ligated, blood can bypass the occlusion through the genicular anastomosis and reach the popliteal artery distal to the ligation. Other clinical problems which we can encounter in the popliteal fossa is the popliteal abscess or the tumor. Since we read that the deep popliteal fascia is strong and limits expansion, so pain from an abscess or tumor in the popliteal fossa is usually severe. The popliteal abscess tends to spread superiorly and inferiorly because of the toughness of the popliteal fascia. Other important feature of the popliteal fossa is that the popliteal pulse can be felt. Since the popliteal artery is difficult, it may be difficult, but it can be performed with the person in prone position as seen in this diagram, with the knee flexed to relax the popliteal fascia and the hamstrings. The pulsations are best felt in the inferior part of the fossa, where the popliteal artery is related to the tibia. Weakening or loss of the popliteal pulse is a sign of femoral artery obstruction. Now, another clinical aspect is semi-membranosis bursa swelling. It is the most common swelling found in the popliteal space, and it is made tense by extending the knee joint, and it becomes flaccid when the joint is flexed. It should be distinguished by Baker's cyst. So this is a Baker's cyst which is centrally located and arises as a pathological diverticulum of the synovial membrane through a hole in the back of the capsule of the knee joint. So whenever there is a differential diagnosis is being made of semi-membranosus bursa swelling, Baker's cyst, which you can see in this diagram, should be differentiated. Another is the popliteal artery entrapment syndrome, which is commonly seen in young healthy athletes, but can also be seen in drivers of trucks, buses, and military vehicles. Since all these activities require repeated forceful contraction of the calf, that results in hypertrophy, and the popliteal artery can be entrapped. Symptoms are sudden in onset during exercise and includes paresthesia, blanching, coldness, and cramps. It is a rare cause of lower extremity ischemia that mostly common presents in young athletics. So, in order to summarize the popliteal fossa, there are some cadaveric pictures. So when you do in dissection, these cadaveric pictures will help you to identify these structures and memorize all these structures. So they have been labeled and the index has been given on the next slide. So this is a superficial dissection of the popliteal fossa, and you can see the diamond shaped fossa very well. These are the superior, lateral and medial boundaries formed by the biceps femoris, semi-membranosus with the semitendinosus, the lateral and the medial head of gastrocnemius. We can see the small saphenous vein. Followed by a deeper dissection, you can see the artery and the nerve. Here there is the sciatic nerve dividing into tibial and the common peroneal nerve, and the arteries giving branches, muscular branches. Now the boundaries have been cut and the deeper dissection has been done. Again, to show the arteries, the genicular anastomosis, the superior medial, the other genicular anastomosis arteries, which you can see here. The tibial nerve giving branches to the muscles, the common peroneal nerve giving branches. This muscle is the soleus, which is a deeper muscle. Now this is a last diagram which shows very well the anastomosis. You can see the inferior lateral, medial, superior lateral, medial genicular branches of the popliteal artery. So this is an index which has been given. So the references have been taken from these books which you can refer, and brainstorming few questions have been given so that you can assess your knowledge, and that's all for the popliteal fossa. Thank you.